like to say is everybody that's joining, if I mean, apart from yourself, and it's good to see so many different types of dental professionals online, because this is the new platform that we have to get used to in terms of learning and actually achieving, sharing resources and doing different types of CPDs. All right, so from my understanding, in Ghana, when you guys do your technician training, there's not many students who actually undertake orthodontics as a specialism. Now in UK, you have different types of orthodontic therapies. You can have a clinical side, and then you can have the technician side. The clinical side, you will study for approximately 5 years as a dentist, then 2 years within a hospital, then another 3 years. So 5, 6, 7, 8, 9, 10. So you're looking at 10 years in order to become an orthodontic specialist. Now on the technician side, you would do this based over the number of 2 to 3 years, but it's very compact, because we would base 16 different units where you would learn how to become a technician on various different disciplines. So what I'm planning to do today is I'm planning to introduce people that may not be familiar with orthodontics to the introduction of orthodontics. And I'll just show you guys a brief introduction of what we're going to be going through today. So our objectives for today is to identify the definition of orthodontics. We'll also look at explain the difference between dental laboratory orthodontics and clinical orthodontic appliance therapies, and which is essentially saying that we'll look at the clinical side and we'll look at the technical side. And the technical side is what the technician would do. We'll look to understand the role and responsibilities of dental laboratory technician, and to identify the different types of orthodontic clinical and technical appliances. This presentation will mainly be based on the technical side, but we'll look at 1 or 2 different clinical appliances that a technician possibly may also do. What I would like is for you guys to hold any questions that you have toward the end, and then just ask it or type it into the chat format so that we can answer these questions at the end.
Mr. Prempe, sorry for interrupting. Please kindly be checking if some people want to join you, kindly let them join from your end. You are now controlling the thing now.
Okay, so I'm having a look at it, and let's see.
The participant, if anybody wants to join, kindly allow the person.
Yeah, understood. Let me change this thing then here. Admit. I thought you guys would be doing this on your end, but so I have to do it. Okay.
Yeah.
Admit. So obviously you guys have to bear with me as I let people into the platform as well. And admit. All right, so for those of you that just joined, this is the objectives for today's PowerPoint presentation. We're going to be looking at the specialism of orthodontic principles, and this is based on what the technician would do. So even though it's based on what the technician would do, I'm trying to give you guys a bit of basic information on what the definition of orthodontics is, but also I'll give you a little bit of background information on the clinical side as well. Because as orthodontics is a specialist field where we have to understand how to achieve the various different types of tooth movements, and also the definition of the various different types of appliances that we use within orthodontics, okay? So I went through all the different objectives that we're looking to achieve today with some of these people. If you've just been let into the group, you can just have a brief scan or a brief look of some of these objectives that we're looking to achieve today, which is to understand the definition of orthodontics, explain the different types of dental laboratory orthodontics and clinical orthodontic appliance therapy, to understand the role and responsibilities of dental laboratory technicians, and to identify the different types of orthodontic clinical and technical appliances. It might seem like being back at school, but I would like if you guys, take some notes and then ask me some questions at the end. All right, so let's look at the definition of orthodontics. Orthodontics is a specialized branch of dentistry concerned with managing facial growth, development of the dentition and occlusion. The intention of orthodontics is to treat, prevent irregularities of the teeth, jaw, which is commonly known as malocclusion. So essentially, if you look at my facial profile, I have a normal bite. If I have a protrusion of the maxilla, which is the upper jaw, or a protrusion of the lower jaw, then this can be described as malocclusion, which means it's not a normal bite. So anything that is considered as not a normal bite is known as malocclusion. Now, a combination of various appliances are used to achieve specific types of tooth movement and correct different types of malocclusion. So let's look at what malocclusion is. So malocclusion means teeth are not aligned properly. There are different categories of malocclusion as well. And this is why it's so important when it comes to orthodontics and why it's a specialized discipline of dentistry. Because for the technician and even for the clinical dentist, which is an orthodontic specialist, you know, they have to study for a number of years in order for them to understand the different types of movements or malocclusions that they're trying to correct. Now, when we come to malocclusion, there are 3 different types of malocclusion. There is class 1, class 2, and class 3. I put this slide on here to just give you guys a basic understanding of class 1, class 2, and class 3, but I'm going to go into more in-depth detail about, or more technical detail of what class 1, class 2, and class 3 is. So let's say, for example, class 1 malocclusion is the most common. The bite is normal, but the upper teeth is slightly overlaps the lower teeth. So with a class 1 malocclusion, you can have the upper maxilla, which slightly protrudes approximately 1 to 2 millimeter above the lower mandible. And this is normally known as a normal bite. We say normal because when it comes to orthodontics, we're talking about aesthetics. We're talking about how the patient looks facially and physically. Even though there's underlying issues in terms of oral health care and chewing and speech and so forth, primarily, we're talking about aesthetics, how the patient looks. Class 2 malocclusion has an overbite, which occurs when the upper jaw and teeth severely overlaps the bottom jaw and teeth. So for class 2, we're looking at the upper teeth slightly protruding over the lower teeth. And for class 3, malocclusion has an underbite, which is when the lower jaw protrudes or juts forward, causing the lower jaw and teeth to overlap the upper teeth and jaw. So for a class 3, we're looking at a protrusion of the lower jaw. So that was a basic definition of what these occlusions are. Now I'm going to get a bit more technical and show you guys the technical definition of class 1, class 2, and class 3 when it comes to malocclusion. So when it comes to malocclusion, we have 2 different definitions. We have angles classification, and then we have anterior classification. Angles classification is based on posterior relationship. So posterior relationship meaning the back teeth relationship. And anterior relationship obviously is meaning the central relationship of the anteriors, whether it's the central anteriors or the canine relationship. So for a class 1, the mesiobuccal cusp of the upper first molar occludes with the mesiobuccal groove of the lower first molar. What this essentially means is the mesiobuccal cusp of the upper first molar occludes with the mesiobuccal groove of the first lower molar. So I just want to ask, can you guys see the mouse, the pointer that I'm using?
Yeah, I think it's clear. I can see from my end.
Okay, okay, good. All right. So for class 1, what we have is if you look at the mesiobuccal cusp of the upper maxilla, this is the first molar. It's sitting inside the groove of the lower first molar. And this is how we would classify the Untitled classification of class 1. And this is based on a posterior relationship. So I want you guys to bear with me. This might be a bit technical. You know, we're looking through all of these, but for orthodontics, it's very important for you guys to understand this, because even if you're doing denture setups and so forth, we want to try to achieve a class 1 relationship with certain setups that we're doing. So it's important for everybody to understand these. And for class 1 anterior relationship, the lower incisal edge occludes or lies immediately below the cingulum plateau of the upper central incisors. So this is what would be known as an anterior classification of a class 1. So you would have the upper maxilla slightly protruding over the lower mandible, and then you would have like a 1 to 2 millimeter overjet. And this is what people would commonly say is a normal bite. Now we come to class 2. And class 2, you're looking at, so for class 2, we're looking at the posterior relationship again, which is the Untitled classification. I'll just admit more people into the group. Posterior relationship again, which is the Untitled classification. And then we also have the central or the anterior classification. So for class 2, the Untitled classification is the distal occlusion, where the mesiobuccal cusp of the lower first molar occludes distal to a class 1 relationship. So again, we're looking at the mesiobuccal cusp of the lower first molar now, which is here. So this is mesial. And if we look at the occlusion between the upper and lower, it occludes distal to a class 1 relationship, which essentially means that, you know, a class 1 relationship being approximately 1 to 2 millimeter overjet. This is what we have here between the lower first molar and the mesiobuccal cusp. And then we look at the class 2 anterior relationship, because remember, Untitled classification is based on posterior relationship, but the central relationship or central classification is based on anterior relationship. So now we're looking at the class 2 anterior classification. And if we look at class 2 can be divided into 2 subdivisions. Here's where it gets a bit confusing. And normally if I teach my students this, I'll split it up into 2 different subjects. But I just want to give you guys a bit of background information on the different anterior classifications that we have. So when it comes to class 2, you can split it up into 2 various different classifications. So class 2, you can have division 1, and then you can have division 2. However, if we look at a normal class 2 anterior relationship, the lower incisal edge lies posterior to the cingulum plateau of the upper central incisors. The overjet is minimal or increased, and there are 2 subdivisions. All this is saying is that, for example, class 1, you would see this anterior teeth here lying approximately about 1 to 2 millimeter overjet over the mandible. But for a class 2, we're looking at approximately 2 to 6 millimeter overjet of the upper maxilla. Now, what makes this a division 1 and a division 2 is the positioning of this anterior maxilla. So if you look at this upper central incisor, it is proclined. And procline just simply means pushing forward. Now, if we look at division 2, the upper central incisor is retroclined, and retrocline is essentially pushing inwards. So for class 2, you can have the maxilla protruding forward, but if it's protruding forward within a certain amount of degree, then that's proclined. And if it's still have a gap, but still pushing back, then that's retroclined. But it's still a class 2 because there's approximately 2 to 6 millimeter gap in between the maxilla and the mandible, the centrals. And then we look at class 3. So now we look at class 3 occlusion. Sorry, I'll just be letting people in as I go along, so please bear with me. Class 3 occlusion. So class 3 occlusion, I know many people used to laugh at people that had class 3 occlusion because their lower jaw is pushing forward. Yeah, this is what will be known as a class 3 occlusion. The lower jaw is pushing forward. So again, now we look at class 3 or mesial occlusion. The mesial-buccal cusp of the lower first molar occludes mesial to a class 1 relationship. Now, if we look at the Angles classification, and remember, Angles classification is always based on posterior relationship, which means back relationship, which is this. So this is angle classification. Now, if we look at class 3, you can see that there's a difference between, whereas class 1 and class 2, the first molar was occluding within, even the upper first molar was occluding with the lower first molar. But when we come to class 3 and start to look at it, the lower first molar is what's occluding with the upper upper second premolar. You know, so this is essentially telling us that automatically we can see that the lower mandible is protruding forward. And then we look at the anterior relationship for a class 3, which is the lower incisal edge lies anterior to the cingulum plateau of the upper central incisor. And the overjet is reduced or reversed. So if we look at this image here at the top, which is looking at the anterior relationship, we can see that now for a class 3, the lower jaw or the lower mandible lies in protrusion or more anterior to the upper maxilla. So now we can see that obviously if somebody is born with a class 3 malocclusion, they would be looking like, they will have a profile, which I'll show you guys, or something like this. And this is looking at, this image here is looking at skeletal profile of a class 1, class 2, and a class 3. And clearly, if you look at the lips profile, you can see the differentiation between class 1, class 2, and class 3. But also if you look at, you know, the posterior relationship, you can see the difference as well between class 1, class 2, and class 3. And what is determined to be a normal occlusion, you know. Now, what's so important for us to understand is that even though you can have a class 1, class 2, and class 3 malocclusion, when it comes to orthodontics, you can also have various different types of, sorry, I'll just let people in again. Okay, yeah, so what's so important is to understand is that within orthodontics, you can have class 1, class 2, and class 3 malocclusions. However, this is not all that we're concerned with, because when it comes to orthodontics, you can also have different types of tooth movements and various different degrees of malocclusion. I'll let somebody in again, sorry to say. It's so important for us to understand why we do what we do and understand the theory behind what we do. Because even in class 1, normal occlusion, what is known as a normal occlusion, you can have cross bites of the front anterior teeth. You can have crossbites of the back anterior teeth and back posterior teeth. You can have crowding of the teeth. You can have what is known as an open bite. You can have protrusion of the anterior teeth. You can have a deep bite. You can have an underbite. You can have a spacing. And due to certain different types of oral habits, such as thumb sucking or finger sucking, patients can develop some of these different types of open bites or cross bites, crowding, deep bites, undercuts, or protrusions. So you can have a class 1 patient who's got some of these different malocclusions. You can have a class 2 patient who's got some of these various different types of malocclusions. And then you can have a class 3 patient who's got some of these various different types of malocclusion. Okay. All right, so now let's look at the benefits of orthodontic treatment. Why do we do orthodontic treatment? Because primarily, orthodontics used to be for children and teenagers, but obviously now that time are progressing and people are becoming a little bit more wealthier, we're having even adults undertaking orthodontic treatment. So there are 4 fundamental reasons or advantages for undertaking orthodontic treatment. And the first will be to restore the dental arch stability. Restoring occlusion allows the dental arch to sit correctly, stopping the drifting of teeth after treatment. So if you've had a teeth extracted or if you've lost a teeth, if you don't have orthodontic treatment, what could potentially happen is you get some drifting of your posterior teeth or anterior teeth, which would close the gap and will prevent you having restorative treatment in order to fill that gap with maybe a crown or a bridge or an implant as per se. Secondly, to improve aesthetics, as well as improving the smile and overall look of the patient, the position of the dentition has an effect on the patient's facial appearance and profile. This is often seen to be the most important reason why patients want orthodontic treatment. So when we looked at the skeletal profile of class 1, class 2, and class 3, if you looked at a patient who has got, tooth protruding, obviously it's not aesthetically pleasing. And sometimes, even for young children and teenagers growing up, this can seem, a bit of an inconvenience because they may get bullied at school. So there's socio-economic implications to not having a normal malocclusion or normal dentition. Third reason is to restore function. This is the most important reason for undertaking orthodontic treatment. Malocclusion can have a dramatic impact on speech and eating. We understand that even sometimes when you have removable prosthesis fitted, whether it's a dentures or so forth, you might find it difficult to speak. So if you find it difficult to speak with a dentures, let alone having orthodontic appliances or having, various different types of malocclusions, this can make it quite difficult for you to speak the normal way that you generally would do. So this is why we want to fix and restore function to people's dentition. And generally to improve the patient's oral health, because it's a lot easier for you to maintain good oral hygiene when your teeth don't have so many undercuts, where you wouldn't get food traps, which could cause caries and cavities and so forth. It's a lot easier for you to floss your teeth, use things like interdental brushes or TP brushes and so forth. So sometimes this is easily overlooked, but once the teeth are aligned, they are less prone to damage and it's a lot easier to maintain good oral health. I'll just let somebody else in. All right, so we looked at some of the advantages of having orthodontic treatment. 10 minutes, so cool. Okay. All right, so we looked at some of the advantages of having orthodontic treatment. With orthodontic treatment, we can also have some disadvantages as well. And this is why it's important for us to understand what we're doing, what we are trying to achieve, and how we can achieve the aim or the desired tooth movement that we're trying to go for. Because if you don't know what you're doing, there are some disadvantages that can occur as well. Even if you know what you're doing, there are still some disadvantages, but having an informed or an educated theory or principle of what you're doing will minimize these risks. So you get some root resorption, and root resorption essentially is the shrinkage of the roots of the teeth. So during orthodontic treatment, it is accepted that some root resorption will take place. It's estimated that over a 2-year period, up to 1 millimeter of resorption can take place. However, this can increase or decrease depending on the patient's oral health condition. This may be due to certain medical conditions, whether they're diabetic, have heart conditions, or whether they're smokers and so forth. Soft tissue damage. Traumatic ulcerations can occur during orthodontic treatment due to the use of laboratory fixed and removable appliances. Placing an increased amount of pressure on the tooth can lead to a reduction in the blood supply to the pulp and even pulpal delf, possibly leading to tooth loss. Essentially, what this is saying is that if you are not applying the correct amount of pressure on an individual teeth, what can happen is that tooth may experience pulpal delf, which means the root or the apex of the roof will die away. And sorry, I'll just let somebody else in. Okay, so yeah, the root will die away. The nerve inside the root itself will die because of the amount of force that you're applying onto the tooth. And obviously this is not going to be convenient for the patient, because orthodontics, we're dealing with aesthetics, particularly for adult patients who are paid, a considerable amount of money. They paid so much money to have this treatment, and now you've made their tooth loose or you've made their tooth come out, and what's going to be the resultant outcome? So like we spoke about before, or Zanetta spoke about before, when you're looking at ethics and patient's consent and so forth, these are all things that you have to consider when you're treatment planning to make sure the patient understands some of the issues that can occur before you undertake orthodontic treatment. Relapse. At the completion of orthodontic treatment, teeth attempts to slip or fall back into a former state. This is often due to the lack of patient compliance with using the retention appliances instructed. And this is particularly important. I mean, it's important for young children, teenagers, but this is particularly important for adult patients, because adult patients, their oral anatomy, their jaws and their soft tissues are more developed. So what happens is they're more likely to get relapse. Hence why we use various different types of retention for adult patients, and different types of retention appliances when it comes to teenagers or young patients. But we'll look at this again further on within the PowerPoint presentation. All right, so, sorry, let me just let somebody else in. I think one person is waiting. Nope, I think that's okay. All right, so what I wanted to do is I wanted to give you guys an understanding of when we're trying to achieve tooth movement, how does it actually occur? And what I wanted to do is show you guys there are maybe 5 different types of tooth movements that we use in orthodontics, but even these 5 different types can be broken up into subcategories. Okay, so when we're looking at tooth movement, it's important to understand the different types of tooth movement that can take place. Now, the first one I'll talk about is tipping. Tipping is when the apex of the root remains in roughly the same place, only the crown of the tooth is moved. So essentially what this is saying is, this is the root of the tooth. It would roughly stay in the same place, but we're trying to achieve movement of the crown, which is here. So you may get a small degree of movement for tipping in the apex, but primarily the majority of the movement will be in the crown. And then you get bodily movement where the whole tooth, crown, and root moves. So bodily movement, different from tipping, would be where you move the whole tooth itself. So this would be moved backwards or forward, depending on where you apply the force or the pressure. And then you have rotational movement. And rotation of the tooth is around its long axis. So this will be when, if you have this tooth here, where you're spinning it around. So essentially you have the tooth, whereas tipping, you're moving the crown, which is here. Bodily movement, you're moving the whole tooth. When it comes to rotational, let me go back. When it comes to rotational, you're moving the tooth on its long axis. So this is rotational. And then we come to extrusion, which is elongation or elevation of the tooth, which is pulling the tooth down. And when I used to work in the hospital, you may have some patients who have had their permanent tooth not erupting properly. So what we'd have to do is that we'll have to make an incision on the gingiva and then place a bracket on the tooth that's not fully erupted, and then gradually over a number of weeks and months, just pull it down every time they come for an appointment within the orthodontic surgery. And this is extrusion. And then you have intrusion, which is depression of the tooth back into the occlusal plane or attempting to prevent its eruption. I'll just let some more people in, sorry. So with intrusion, sometimes this may be, it may even be a trauma case. You know, we had a lot of children who played in the playground and sometimes they knocked their tooth and their tooth came out. And as we understand as dental professionals, this advice is very valuable. If somebody is knocked their tooth, particularly a young child or a young adult, if they put it in milk, or if they don't have milk, they can put it in saliva in a small pouch. If they come to the dental practice within a day to within 24 hours, we can put this tooth back into the oral anatomy and then attach a bonded wire to it. And this will allow the bone or the alveolar bone to fuse around the tooth. And we've done this numerous amount of times within the hospital settings, you know, and particularly for young patients, this is quite important because why would a young kid need to lose particularly a central teeth because of an accident when we can clearly put it back and allow them to have, you know, their tooth for another 20 years or 30 years or 40 years and so forth. You know, so this is quite important when it comes to intrusion as well. All right, so now, and the reason why I spoke about tooth movements is because I wanted you guys to understand that trying to achieve all these various types of tooth movements depends on the different types of appliances that we use in orthodontics as technicians. You know, you have the clinical side, but you also have the technical side. So I wanted you guys to understand how tooth movement works, the different types of tooth movements, and this is just a basic understanding because we can go more in depth at another time. But if you look at this image here, and you look at the gingiva here, or the periodontal ligament, sorry, it kind of illustrates how orthodontic forces work within the periodontal ligament. Because here you have an equal amount of periodontal ligament on either side, but when you apply the forces to the right-hand side, you can see there's a compression of the periodontal ligament here. And where there's a tension side on the left side, you can see there's a widening of the periodontal ligament. So I'm gonna speed up a little bit because obviously Zoom doesn't allow us to have so many minutes anyway. So what I wanted you guys to understand anyway is that there's things known as osteoclasts and osteoblasts. And these are what maintains the compression side and the tension side of tooth movement. Because osteoclast, what we do is bone resorption, which means it would actually remove bone from where you're pushing the tooth. So if I'm pushing the tooth to this left side, as this arrow indicates, then there's something that's known as osteoclast, which would eat away at this bone. And there's something known as osteoblast, which would remodel the bone on this side as well to form new bone. But this is something that I'm going to fast forward on because as technicians, it's good to understand it, but we don't need to go too much into detail of it. All right, so when we look at different types of treatment, we have the clinical type and we have the technical type. When it comes to the clinical type, there are various different types of fixed appliances that we can use. The most common ones are known as beg and edgewise. And then when we come to the technical side, which is what a technician would do, there are, sorry, 1 second. Just admitting people. There are removable, functional, and fixed appliances. It's important not to underestimate the role of a dental technician in orthodontics. The technician has the responsibility to manufacture a wide range of different orthodontic appliances. And these are removable, fixed, functional or myofunctional, and orthodontic surgical splints. So let's have a look at, all right. So all appliances should be manufactured to a high standard. If not, the appliances are fitted, and this can often hinder a patient's treatment and cause unwanted tooth movement. Now, if we look at laboratory-made fixed and removable appliances, these are constructed to be passive in their nature, and passive just essentially means that it's the orthodontics or the clinician who would activate it. So when we make it calm, and the orthodontic will one that will apply the pressure to achieve the desired tooth movement. A clinical fixed appliance is attached to the teeth so that it cannot be removed by the patient. And there are two main types, like we spoke about, which is edgewise or beg. And these appliances are active in their nature. Now, active just essentially means that, imagine if you have braces put on your teeth, straight away you can feel the pressure and you can feel the force. And this is what active appliances mean. So passive means no pressure, active means pressure. And then we have retention. And this stage is considered a very important stage, as retention is the time in which the alveolar bone is remodeled and periodontal ligament is reformed. So after every type of orthodontic treatment or tooth movement, we have the retention stage where we produce different types of appliances. All right, so now let's look at removable appliances therapy. Removable appliances is something that consists of a number of components which can be removed by the patient and clinician for maintenance, adjustment, and repair. So simple removable appliances therapy is the term given to a patient's stage of treatment, or a way of providing treatment where removable appliances are used. So removable appliances consist of various different components, and there's an easy way to remember these components, which is RAAB. RAAB essentially means retentive, active, anchorage, and base plate. So RAAB. For every single removable appliances that we do, we have a retentive component. And as the name indicates, these components are designed and used as a form of retention. Retention is the resistance to displacement away from oral tissues. So if you have a look here, you have an Adams crisp on this appliance here. You have a double Adams crisp on the front anteriors. But then on this appliance here at the top, you also have a labial bowl. And these are retentive components. You also have occlusal stops, which are retentive components, which means they prevent movement of the teeth against the forces, the loading forces. And then you have active components. Active components are designed and used to generate the forces that result in tooth movement. And they come in various forms, such as springs, screws, and elastics. So on this upper appliance here, you would have a midline expansion screw, which is known as an active component, because it's actually applying force to widen the arch. And then you also have this spring here, which is a palato-helical spring. Then you have anchorage, and I'll come back to anchorage, but let's look at base plate. The base plate of removal appliances is the most important component, often constructed from cold cure polymethyl methacrylate, which is just acrylic. And this component has a number of key functions, including housing, protecting active components, retention of retentive components, and distribution of forces. Essentially, what it's saying is that this is the base plate. So this is an acrylic base plate. And whereas if you make a denture, for example, You know, denture, we get retention from the base plate. For orthodontic appliances, we don't get retention from the base plate. We get retention from these retentive components. So the base plate can even be small, depending on the type of patient that you're making it for. But the base plate holds the tooth in place. If you can see how tightly it's hugging around the palatal aspect of these teeth, all of these teeth here, because if there was a gap, these teeth would move forward. And this is what is known as anchorage. So holding all these different components and appliances together to achieve the desired aim or the desired tooth movement is what's known as anchorage. And this is just trying to illustrate some of the things that we would do when it comes to orthodontic appliances and how you can have various different types of components. So here you have a Z-spring, which is a double cantilever. You also have anchorage provided by a posterior bite plane, which is posterior capping of this teeth. So this molar here would not move because that's the desired tooth movement that the orthodontic is trying to achieve. But then you also have a retentive component, which is known as a south end clasp on the central incisors. And then you have a spring component, which are active components, which will be boxed in and exposed underneath the acrylic wire work. So again, showing different types of removable appliances. You have a T-spring, you have a double cantilever Z-spring. And the good thing about removable appliances is that you can also do modifications and additions. So we looked at posterior capping, which is posterior bite planes, which can be added to removable appliances. But then you can also have pontics or tooth additions added to removable appliances. And there are various different types of spring or active components that you can have, whether it's Z-spring, double cantilever, T-spring, buccal canine retraction, and so forth. All right, so now, and bearing in mind, all these appliances would be made by a technician. This is not something that's made by a dentist or an orthodontist. It's made by a dental technician who specializes in orthodontic technician. So now we go to the fixed appliances, and the definition of a fixed appliance is an appliance that is fixed within the patient's mouth, teeth for changing the relative position of the teeth. And when it comes to fixed appliances, there are two different types. So we have the technical side or the laboratory side, and then we have the clinical side. Like we spoke about before, the clinical side is the beg and the edgewise. But when it comes to the technician side, it's primarily a band will be cemented onto the molar teeth, and then they will have a wire component. The wire component may be made of 0.9 to 1 millimeter stainless steel wire. And often receiving the impression, the bands are also embedded into the impression. So when we pour the model and turn it upside down and take the impression mode off, the bands will be situated on the model already, or the orthodontist may send the band to us in the dental laboratory for us to place it on the model. So just to give you guys an example of some of the fixed appliances that you can make as a dental laboratory technician, you know, there are TPAs, RMEs, various different appliances, and you can also have various different types of modifications, you know. And I had two different links here to show you guys like a short 1-minute video of how these appliances achieve their tooth movement. But I don't know if we have time for that, Shaibu. So
yes, you can go ahead.
You can go ahead. Okay.
Yes, please.
Okay. All right. So I'll show you guys an example of how we can use a fixed appliance to achieve a desired type of tooth movement. All right, so can you guys see the screen?
Yeah, very clear.
Okay. All right, so I'll just play this short video anyway. So for example, this is a fixed appliance with the two bands placed on the first molars, and then you have an expansion screw in the middle. And then you can also see the various different types of malocclusions on the anteriors. So they would use their dental laboratory fixed appliance to start the treatment. And then after they've expanded the arch, then they would use a clinical fixed appliance to achieve the desired normal occlusion that they wanted. And also when it comes to fixed appliances as well, you can have habit breakers, which are for patients that may suck their thumbs. And just to give you guys an illustration of how this will work as well is, so you could have something like a habit breaker. Where if you've got a patient that's sucking their thumb, over a number of years, obviously this is going to cause protrusion of the anteriors. And what we will do as a technician is produce a fixed appliance which could correct this, because every time they put their thumb in their mouth, this anterior section will stop them from sucking their thumb. And this will be used over the course of a number of months, sometimes even a year to 2 years, to correct the various different types of malocclusion that occurs within these patients. Okay, so I'll carry on with the slide. All right, so then we have removable, fixed, and then we come to functional appliances. Functional appliance within orthodontics is an appliance that alters the posture of a mandible, causing stretching of the facial soft tissues to produce a combination of dental and skeletal changes. Normally, functional appliances is used to correct class 2 and class 3 malocclusions. And this is why orthodontics is quite complex, because there's 3 different disciplines. You have removable, fixed, functional, and myofunctional. And this is just an image of some of the functional and myofunctional appliances that we may come across within orthodontic discipline. So if we look at this, it's slightly different to the simple removable appliances that we looked at. This is using a combination of soft tissue to the hard tissue to achieve the desired tooth movement or oral anatomy changes that we're looking to achieve. So, and this is primarily used in patients who are growing up, so teenagers. It's not normally fixed appliances. Functional appliances are not normally used in adult patients. And like I said, the last section of it is the retention, which after every single type of orthodontic treatment, we come into the retention part of it. And when it comes to retention, there are various different types of retention components that we can have. We can have the ESSIX retainer, which is used in adults and teenagers similarly. And we have the Hawley retainer, which is majoritively used in teenagers. And some of these have pros and cons. They can be easily repaired, which is the Hawley retainer. This ESSIX retainer here can diswarp if it's in heat. It can morph quite easily. But some of the advantages of this is that you can also add contics within it. So you can have tooth additions to ESSIX retainer and also Hawley retainers. Some of the disadvantages of Hawley retainer is that you have this metal component of the labial bow, which sits in front of the teeth. So if you're using it for teenagers and try to encourage them to wear it, they might feel a bit uncomfortable wearing it. And then we have the fixed bonded retainer, which is the third form of retention component, which is used primarily in adults, because adults, our jaws are fused already. And when we have orthodontic treatment, we're more likely to get relapse. So we used fixed bonded retainer on adults, and there are various different types of wires and various different types of designs that we can use for adults as well. Okay, so this is a link just to give you guys a bit of background information on the different types of orthodontic appliances. So if you want, you can take it down. And I didn't speak about Invisalign and, oh, sorry, there's a few people that I have to admit. I didn't speak about Invisalign, and I didn't speak about mouth guards, and I didn't speak about, things known as bruxism appliances and so forth. But this is something that we can touch base on at a later date. So if you want a bit more information on different types of orthodontic appliances, this is a link that will give you a bit more information. And if you want a bit more information on 6-month Smile or Invisalign appliances as well, this is a link that will give you a bit more information on that as well. So thank you guys for taking part. I had to rush through a little bit because of Zoom and time restrictions, but I open the floor to you guys for any questions that you may have.
Prempe, kindly make me the host back so that I can moderate the questions for you.
Okay, so where would I do this?
Go to the participant. Look for me at the participant section.
Okay. So more.
My hand. There's a function you can actually apply. If you go to the last end, if you click, you can raise your hand. Yes, Majid, your hand is up. Let me look for you and unmute you. Yes, Majid, unmute yourself and ask your question. Yes.
Yeah, good evening to everyone. And then I want to thank the moderator. He has done very well. And actually, I've enjoyed the lecture. My question is, a child about 6 to 9 months who sucks the finger, especially mostly is the thumb. What can you do in order to stop the said child from sucking the thumb to prevent the child from having malclusion in future? That is my question.
Okay, yeah, welcome. So from my understanding, you're asking of a child from 6 to 9 months. Is that the case?
Yes, that's the case. 6 to 9 months.
Okay.
Yes.
All right, so when children are usually that young, obviously we cannot make orthodontic appliances for them to wear because it's not going to stay in their mouth. They're not going to wear.
Mr. Pepper, kindly unmute. Okay, good.
Can you guys hear me?
Yes.
Okay, yeah. So what we do is we encourage you guys to use different methods to get these children from sucking their thumb. And this is, grandma's therapy, whether it's, you put some acacadro on the thumb or, you try to use different methods to try and prevent them from sucking their thumb, because when they are so young, there's only a small amount of different orthodontic means or dental means that we can use to prevent them from doing it. So it's just about encouragement and you having the education to know that, okay, fine, the longer they suck their thumb for, the more problems they're going to have as they get older. So you try to encourage them. And particularly, this is the most important thing as well. When a child turns to 1.5 or even 1 year old, it's good for them to come to the dental practice. They don't even have to have a checkup, but just to introduce them to the clinic, let them see the environment, let them get introduced to the dental nurses and the clinicians and get used to the environment so that when they're 1.5, 2 years old, they feel more comfortable when they sit in the chair so that we can actually apply all these different types of methods or disciplines that we need to do. But the only thing I can say is just use, just use awareness and knowledge to try and encourage them not to suck their thumb at that age because they're very young,
Yes, any other person with a question? Let me see your hand up. Okay, Huawei. Sorry, I'm using the Huawei Y Prime. Kindly unmute yourself and then talk.
Yes, my name is Kujopong. Mr.
Okay.
Trump, I want to find out. Can you hear me?
Yes, it's loud and clear. Mm-hmm.
Right. I want to find out with CAD-CAM being used nowadays in almost everything in dentistry for either zirconia, all these appliances and all that. Has it actually made such striving breakthroughs in orthodontics? The laboratory aspect of it. And if it has, can you perhaps maybe give us 1 or 2 examples of such orthodontic appliances that CAD-CAM is being used in fabricating? Thank you.
That's an excellent question. Yeah, good evening. You're welcome. So, the reason why that's an excellent question is because this is where the future of dental technology is going, and you asked for 2 examples. So I'll give you 2 examples. One example is 3D printed models. So whereas before we used to pour up our models in gypsum or plaster of Paris or whatever it is, now a dentist can take an intraoral scan and then send that file digitally to the dental practice. The dental lab, where we can now 3D print this model. So this is one example. You know, because we can 3D print this model, that file is never going to get lost. So even if we make a mistake, we don't need to get the patient back into their clinical surgery. We just reuse that same file that we've got. You know, that's one example. Another example as well is that, you know, if we're doing things like orthodontic stents and even mouth guards and so forth, we can 3D print these, you know, because these are a form of acrylic or plastic. Anything that's plastic can be 3D printed now. You know, so even ESSIX retainers, now we're looking at Invisalign 6-month smile appliances, which is essentially a form of ESSIX retainers, which can achieve different types of orthodontic tooth movement. So let's say if you have one teeth that you need a tipping movement, which is just like a simple tipping movement like this. A company can say to you, well, I can achieve this movement for you and charge you a fraction of the price that a fixed braces would cost. And they will do this for you in 6 months. Whereas if you had braces, this would take maybe 1.5 years to 2 years. You know, but they would design this on the computer and then design this movement over a course of 6 months. So you have a different appliance that you wear every single month. And by the end of the 6 months, they've achieved the desired tooth movement that they need. You know, so this is another way that, you know, CAD/CAM is improving our industry. There's so many different developments here that CAD/CAM is bringing to our industry. But again, it's all about cost. It's all about training, you know, and it's not everybody that can utilize this, but gradually we're getting there. You know, and I say to people, you look at it as a tool to your toolbox, not something that's going to take you out of the profession, but it's a tool that's coming to help us to enable our profession to progress.
What of molar bands?
Sorry?
Molar bands.
Yeah.
Molar bands.
Yeah.
Well, molar bands are metal components, isn't it? And molar bands are precision milled components, right? So molar bands is not something that's going to be phased out. You know, you're not going to say, oh, because of CAD/CAM, we're going to get rid of molar bands. It's like even some people are saying, you know, China, they're making dentures and they're milling dentures, but it still doesn't mean that the skill of a professional sitting down and actually crafting a denture from acrylic is going to go out, because the attention to detail is different. You know, even sometimes I get jobs from orthodontics who want me to do indirect bonding, something that's called indirect bonding, which means they want me to place the teeth on the model in the lab and then make a silicone mold and then send it to them and they'll place the brackets with the mold that I've made. You know, so our skill is something that we have to appreciate and we have to perfect and we have to utilize all these different skills that are coming into our industry.
Okay, any other question? Somebody with any other question? Okay, I'll come back to you. Okay, I'll come back to you. Is there any? Okay, Gideon Samevi. Unmute yourself. Okay.
Yeah. All right. Thank you. Good evening.
Good evening.
I would like to ask: is forced eruption same as extrusion? Hello.
Forced eruption.
Yes.
Is forced eruption same as in extrusion?
Yes, as types of the pressures are no stresses applied to the tooth. For instance, this one, maybe you have a root or the tooth is erupting, but then it's being inhibited. So sometimes we fabricate appliances and then we attach bands to it and then pull it up.
Well, I think what you're trying to say, like I explained before, there's difference between intrusion, which is pushing the tooth back in.
Yeah, back in.
Exactly, right. So forced eruption is slightly different. Essentially what you're saying is forced eruption is pulling the tooth out, isn't it?
Yeah, pulling it up.
Exactly. And what we do in the hospital is, if some patients have teeth that's not fully erupted, we will place bands on them, we'll make an incision into the gingiva, and then we will pull this. Yeah. So this is what's known as extrusion.
Yes,
you know, forced eruption, extrusion, they're essentially the same thing. But like I said, within orthodontics, you have different techniques for achieving certain desired type of tooth movements or malocclusion correction. Yeah.
Okay, all right.
Okay, Meshach, your hand has been up. So kindly unmute yourself and ask your question. Yes. So go ahead, Meshach.
Okay, thank you for the opportunity. Okay, thank you. Okay.
Your network is pretty bad. Put your video off. Meshach, put your video off.
Yeah, the lecture has been so educative.
Hello, Meshach. Before you talk, put your video off so that the network can assist you talk. Your video is on. We can see you. Put it off. All right. Any other person with a question? Whilst Meshach does that, then we bring him back. Anyone with a question? Or upon you, go ahead with your other question you wanted to ask. Yes.
Okay, is it better?
You know, can I just say, some people have really bad connection. They can type the question they have in the chat.
Yes.
And then
so you can type it, because Meshach, we can't hear you. Aha, very good. I think now, if you talk, we can hear you. But before then, upon ask your question, because you are on now.
Right. Mr. Premp, I want to find out, you know, when you're doing full dentures or even fixed bridges and all that, the articulators that you use play quite a key number of roles. For example, when you're doing full dentures, you want to use an Archon articulator or a full articulator and all that. Does these articulators specifically, you know, play such complex roles in the field of orthodontics as well? Or in orthodontics, just normal, maybe a simple hinge articulator would just work, or you have to go in for the full articulators?
That's a good question. And what I would say to you is that when it comes to orthodontics, similarly to dentures, you know, if you're doing a complex case, especially if it's a private patient and they're paying a lot of money, you want to use a fully functional articulator, you know, meaning that you might have a face bow with an occlusal bite plane, right? Now, when it comes to complex orthodontic treatment, which involves orthodontic surgery, which means even severing or breaking the jaw in order to achieve class 1 occlusion for a patient that might be severe class 2 or class 3, you're going to need to use a fully functional articulator. So when it comes to orthodontics, we don't use like a simple hinge. You know, we use the fully condyle, you know, the fully functional articulators to kind of try to achieve these movements. But however, it's only used for severe cases like orthodontic surgery and so forth.
Okay, Mr. Prempe, we have about 4 minutes to leave. So I will let Meshach ask the question, you answer. Presdo is online, he comes in and then we leave. Thank you.
Excellent, no problem.
Yes, Meshach, Dodo, please go on with your question.
Yeah, I was asking if a child starts sucking at 4 months, or you wait before you stop.
Meshach, we still have difficulty with phone. Can you type your question? Go to the chat side, type it, and then I'll let him take it up. Okay, thank you. Okay, so Presdo, you're online. Do you have a word for us? Just give us a word or two. You have about 1 minute to do that.
All right. Good evening to everyone.
Good evening.
It's interesting. I have 1 minute to talk to one of us. I hope you're all fine. I believe you are. Let me begin by thanking Mr. Prempe for the wonderful presentation. I followed through, I think, quite very often I was with you. Few of the times missing a little, but I realized that the presentation was so elaborate, and I also saw that a lot of work went into preparing those slides so that we could benefit from whatever we're supposed to know or be presented to us. Mr. Prempe, we are very grateful to you. I think if we had so much time, if it were a face-to-face encounter, I believe that we would have even gotten more, perhaps even with very practical examples. We are hoping that in the near future, we can have a forum where we will all be together and we can have some level of practical exposure. These things that we are doing is more practically oriented. The theory, I'm sure that we may be reading around it, and it is just the exposure, the practical exposure that will at least add some skill and value to what we already know. Exactly. We hope you have that platform someday. Yeah. To every one of us, let me begin. I think that I should, first of all, be thanking everyone. You know, for the past 1 month or a little more, I've been away out of the scenes and enjoying some time somewhere, trying to put a lot of things together so that I can add more flesh to myself. And then when we come back, we'll come back stronger. I want to appreciate every one of us for how you were supporting us throughout the period, myself and my wife. Last Saturday, as you all were aware, the wedding was done. We are together formally now. And I think that we are Ohpag couples. I'm so grateful to every one of you for the support, the prayers, the best wishes that we receive from every one of you. We are so grateful. Now, let me quickly say that we are not in normal times. That is the reason why we're having the Zoom meeting. And obviously, the abnormal times, if I'm permitted to put it this way, has given us the opportunity to explore all avenues for us to have this. And if not for COVID-19, we probably wouldn't even know how we will get Mr. Prempe all the way in UK. We probably will be thinking of him coming down. But abnormal times have helped us to think around and getting to know that a platform like this exists and all of us can get the best out of it. We are also concerned about every one of us. We're not in normal times, so we are thinking that no, we shouldn't pay for conferences, so the association will bear the costs associated with organizing these events and paying for accreditation and the rest. Yes, we will do it so that we can cushion the effects for members to continue to live through these abnormal times. I will just end by quickly saying that if any one of us in any way maybe gets infected in one way or the other, it's not our prayer with COVID-19, please do let us know. If there are some people infected that we are not aware of who are our members, please do let us know so that we can see how together we will get them assisted the best way they can to get through that. I want to thank every one of you for making time to be with us. Tomorrow we are going to have time together. It's going to be a combined program. It's not going to be divided as we have today. It's going to be a combined program. I believe that whatever is prepared for us is definitely going to benefit every one of us. I'm most grateful to all of you. Thank you so much.
Thank you very much, Mr. President. You exceeded your time allotted by several percentage. All right. So, Mr. Prempe, Meshach has given me the indication that he's okay. He has gotten the answer. So he will not ask the question again. So give us your final word and then let's wrap up everything. I don't know, Madam Zenata was around, whether she has something for us in 15 seconds. I don't know. Madam Zenata, if you have something for us in 15 seconds, kindly unmute and tell us.
Hi, no, nothing much. This wasn't my session, so I've just enjoyed it. Okay. And actually learned quite a bit much more about orthodontics. So I'm glad I timed in as well. So yes, no, it's been an enjoyable evening. It's been definitely, we've had shared learning and increased knowledge here. So we look forward to tomorrow's session.
All right, thank you.
I wish everybody a very good night.
Thank you so much. Mr. Prempe, just in 30 seconds, wrap up in 30 seconds for us.
Okay, so basically, I want to say thank you to everybody that participated in this session today. Like Mr. President said, it would be good for us in the future to do more practical-based applications, because I want to really improve the skills of Ghanaian dental technicians when it comes to orthodontics. I mean, we can improve the skills of other disciplines as well, whether it's dentures or fixed and so forth, but I really want to focus on the orthodontics because I know this is something that is not taught. So I want to thank everybody that partook today. I want to thank you guys for organizing it. And also, you know, this is a great platform that we have to utilize. We really have to use this in order for us to share from people from the diaspora and people from different countries so that we can come together and share our resources and our skills. You know, so you guys are doing a good job. Keep up the good work. And also, like I said, you know, or you guys have a saying. What's the saying? You know, our passion, your smile, our passion. Let's keep this up. Let's keep promoting it. And let's keep improving our dental environment. You know, open the gates for us to be able to help you guys and for you guys to also to be able to help us, for all of us to benefit each other. Yeah, so that's all I was saying.
Thank you so much. Colleagues who have made time to join, thank you so much. We are most grateful. I hope we are going to meet on this platform 7 to 8 and enjoy the lessons we have. It will be in the area of infection prevention. We all need infection prevention. It's not any one person's business. Let us make time and converge here tomorrow so we enjoy it. Thank you so much, and good night to everybody. We are most grateful for having you.
Excellent.
Good night. Good night.
Good night.